A 52-year-old male comes into your clinic to establish care complaining of lightheadedness. On chart review, the past medical history includes angina, diabetes, obesity, and erectile dysfunction. Their medications include nitroglycerin tablets for angina, sitagliptin and metformin for diabetes, and sildenafil for erectile dysfunction. His vitals and physical exam are within normal limits, but on orthostatic testing, his systolic blood pressure drops by 25 millimeters of mercury when going from sitting to standing. What is the pharmacologic mechanism behind this presentation? Well, he's on nitrates and PDE5 inhibitors, so that's two vasodilators which shouldn't be taken together. Pharmacologically, nitrates activate on cyclic GMP, whereas PDE5 inhibitors prevent its breakdown. In both cases, we have two meds acting on the same pathway to cause smooth muscle relaxation, and we'll cover the mechanisms in detail here. By the end of this video, you should be able to summarize the mechanism of several major classes of cardiovascular drugs. Alright, so here is all of the pharmacology we'll be covering. Let's start with the dihydropyridine calcium channel blockers, two common examples of which would be amlodipine and nifedipine. So before we cover the pharmacology, let's review the normal physiology. Normally, when an action potential depolarizes a cell membrane, voltage-gated L-type calcium channels open. Calcium then enters the cell, forming the calcium calmodulin complex activating MLC kinase. So what do kinases do? Right, they phosphorylate things. So now we have phosphorylated myosin and actin, which allows for contraction. Dihydropyridine calcium channel blockers work by inhibiting the L-type calcium channel. As a result, calcium does not go into the cell. We don't have the calcium calmodulin complex mediated MLC kinase activation, and rather than contraction, we have relaxation. Alrighty, back to the physiology. So normally, adenylate cyclase increases cyclic AMP, as you can see over on the right side of the pathway. When it does this, it thereby inhibits MLC kinase. More cyclic AMP therefore means less contraction. There are three classes of drugs you need to know that alter this system. So what medications are agonists at the GI receptor? Right, that would be epinephrine and norepinephrine. What would that mean for contraction? Well, activation of GI means less adenylate cyclase, meaning less cyclic AMP and therefore more MLC kinase. And this is how epi and norepi lead to increased contraction. Now, a whole group of medications, including prostaglandins, prostacyclin, and adenosine, lead to the exact opposite. So with GS agonism, we have increased adenylate cyclase, increased cyclic GMP, and therefore decreased MLC kinase and muscle contraction. So why do we have epinephrine under both increasing and decreasing muscle contraction? Well, it has to do with the type of receptors that we're talking about. Alpha-2 agonism increases muscle contraction, whereas beta-2 decreases it. Can you guys think of a case of beta-2 agonism that results in muscle relaxation? Well, the most common one would be giving inhaled beta agonists to relax bronchial smooth muscle with asthma. Alright, finally, the PDE3 inhibitor, milrinone, works similarly, decreasing the degradation of cyclic AMP and thereby inhibiting muscle contraction. Alrighty, so same cell, somewhat different pathways. Whereas MLC kinase phosphorylates MLC, MLC phosphatase removes the phosphate, allowing for relaxation. So let's get the easiest out of the way first. Can you think of cardiac drugs that agonize the GQ receptor? These would be epi and norepi again. Notice the difference on the receptor type and hence the different mechanism of action, as well as endothelin, angiotensin, and vasopressin. As a result of GQ activation, we have an increase in calcium release from the sarcoplasmic reticulum, as well as an inhibition of MLC phosphatase, both of which cause contraction. Alrighty, now on to the other pathway here. The drugs that work exclusively by altering the activity of MLC phosphatase. There are a number of stimuli that can affect the vascular lumen, thereby increasing nitric oxide release. These are acetylcholine, alpha-2 agonists, bradykinin, cytokines, histamine, serotonin, and shear stress. I'm sure that many of you already know that nitric oxide results in relaxation, but let's work through how. So nitric oxide increases cyclic GMP, increasing the action of MLC phosphatase, resulting in dephosphorylation, which causes relaxation. So what is the other class of drugs that has the same mechanism of action? Right, that would be NP agonist. And finally, PDE5 also causes degradation of cyclic GMP, thereby decreasing MLC phosphatase activity and causing contraction. So therefore, what does a PDE5 inhibitor do? Well, it would inhibit this, causing relaxation. Alright, let's wrap up. So drugs that inhibit smooth muscle contraction include calcium channel blockers like amlodipine, GS agonists like prostaglandins and adenosine, PDE3 inhibitors like milrinone, nitric oxide, natriuretic peptide receptor agonists like ANP, BNP, and nasiratide, and PDE5 inhibitors like sildenafil. Drugs that stimulate smooth muscle contraction include GI agonists like epi and norepi, and GQ agonists like angiotensin and vasopressin. So thank you guys so much for tuning in. If you liked the video, go ahead and give me a thumbs up down below, and as always, comments are more than welcome. Study hard and stay healthy, my friends.